Good morning, everyone. It's my great pleasure to introduce our Grand Round speaker today, Dr. Bonnie Zima. Dr. Zima is a professor in residence of child and adolescent psychiatry, vice chair for faculty development, associate chair for academic affairs, and associate director of the UCLA Center for Health Services and Society at the UCLA Semel Institute for Neuroscience and Human Behavior. The title of her talk today is Acute Mental Health Care Use in the United States Children's Hospitals Pre and Post COVID-19 School Closures. Dr. Zima's research is dedicated to improving the quality of child mental health care, with priority placed on children enrolled in Medicaid-funded outpatient programs and underserved at-risk child populations. Her research spans identification of high unmet need for mental health care among high-risk child populations, national pediatric hospitalization resource utilization and costs, validity of national quality measures, pediatric integrated care models, pediatric workforce development, and applications of technologies and clinical informatics to improve child mental health care. Her research has received all 3 National Research Awards from the American Academy of Child and Adolescent Psychiatry. And in addition, Dr. Zima is a member of the U.S. Child and Adult CORSET Annual Review Group for Work Group for Center for Medicaid and CHIP Services, the APA Council on Quality Care, Behavioral Health and Substance Use Steering Committee for the National Quality Forum, and the ACAP Committee on Research. She's the consulting editor for JCAP, the deputy editor for the Journal of Child and Adolescent Psychopharmacology, and a distinguished fellow of ACAP and the APA. And I'll add, she's also an excellent mentor to numerous learners in our department and division, including child and adolescent psychiatry fellows, residents, and medical students. So this morning, please put your questions in the Zoom Q&A. You can ask questions throughout. Submit your questions through the Q&A, and they'll be answered once our session is over. So without further ado, I'll turn it over to Dr. Zima.
Okay, thank you, Juliet. All right. Okay, so can everybody see the screen? I'm going to assume that's a yes. Okay, so this morning I'd also like to acknowledge all my co-authors on this study. Dr. Edgecombe, Jonathan Rodin, who helped with the analysis from Children's Hospital Association, Dr. Susan Cochran, who is in our School of Public Health, Dr. Christopher Harrell, University of Florida, who is a data science expert, Joy T. Patek, Cornell, also a data science expert and expert in EHR phenotyping, Dr. Chi-Hung Seng, who is an outstanding statistician in our STAT core here in our School of Medicine, and Dr. Regina Bussing, who is also a health services researcher and recently just stepped down as chair from University of Florida and continues her work in faculty development. So disclosures, as noted on the title slide, I don't have any investments in the last 12 months that would impact my presentation today. My funding sources for research are from the Mental Health Service Act, the California Cannabis Bureau, and I'm a full-time employee here at UCLA and also part-time LA County DMH. So as everybody has experienced, I imagine, there has been an unprecedented strain on our US children's mental health care system. Even before the COVID pandemic, our existing child mental health system was unfortunately fragmented, ineffective, and unfortunately, particularly in our Medicaid population, quality was poor. The COVID hit and you see increased need for child mental health. Some of the potential explanations were concerns about higher rates of child abuse and neglect that were not being detected in the schools. Reduced physical activity, lack of access to school-based resources, higher rates of parental distress, and among our families, higher COVID-19 related morbidity and mortality. And in addition, a lot of concerns during the pandemic of the healthcare disparities that were always there were going to be accentuated particularly disproportionate increase in social determinants of health among our folks that are from minority race ethnic populations, potentially increased poverty, increased unemployment, less educational resources, increasing food insecurity, housing insecurity, and again, within even the community, disproportionate higher rates of COVID-19 morbidity and mortality. So what was the early evidence for need for child mental health care? When you started to look at the literature as it first came out, one of the first studies, which was pretty amazing, actually came out of the Hubei province in China. And amazingly, they quickly interviewed 1,784 children that were restricted to home. These were kids from 2 different primary schools, grade 2 through 6, from 2 different provinces. And they quickly did the Children's Depression Inventory and the screen for anxiety-related emotional disorders. And what they found in this early study was that 22.6% of the children were screening positive for depression. And of those, more than half admitted worry moderately or a lot about being infected. And almost another 20% of children screened positive for anxiety. And of those, more than a third reported that they worried moderately or a lot about being infected. And what was amazing here was our Orange Journal came out relatively soon with another study examining change in youth mental health during COVID-19. And what was really cool here was that they were already screening for mental health before COVID hit. And so they had a naturalistic study here of a pre-post. And this team then went on to do 3 more post monthly follow-up time points within 1 charter middle school in Texas. The kids were between 10 and 14, grades 5 through 8. They had a sample of 322. And what was remarkable about this Texas school was almost 3/4 were Hispanic. And here too, they found that more than a quarter of children reported feeling a lot or a whole lot lonely. Almost 50% reported some contact with friends through video or social media. Almost a quarter reported stress during pandemic, and more than 28% reported parent stress. And what's kind of unusual here is that they didn't have standardized ratings. This was a survey that they created themselves. But again, the timing was really something, and they were able to turn it around and get it in the top journal. They also had a subset of kids within their study. So they had some data on family functioning, and so they also replicated what we know through our clinical work as well and in the literature, that of those that had better family functioning, they had lower mental health symptoms during the follow-up. And here what's really important is a key study came out in JAMA Pediatrics, and what they did is they did a random effects meta-analysis, pooling 29 studies for a total of more than 80,000 participants. And here what they found was during the first year of the COVID-19 pandemic, 1 in 5 children had increased symptoms of depression, 1 in 4 had increased symptoms of anxiety, and moderators for both of these were more likely with female and older children. So, but what about the impact of changes in schooling on mental health? And here we had a really important study that came out sponsored by the CDC. And it was called the COVID Experience Survey. And it was run out of the team called National Opinion Research Center at the University of Chicago. It's a well-oiled machine doing lots of US household surveys. And for this one, they targeted parents age 5 through 12 and through a very short time period of October 8th through November 13th. And what they found quickly was that almost half, 45.7% of the parents of children age 5 through 12 reported that their children were in virtual instruction. And when you looked at of those that were in virtual instruction, there was a larger proportion of children who were Hispanic at almost 66% and Black, 64%. About 31% of the children during this time period were in in-person instruction. About 23% were getting some type of combined instruction. And in this sample, large majority were in public school. So why care about whether the kid is in virtual versus in-person instruction? Well, according to this quick national survey, they found that children that were in virtual instruction had significantly lower physical activity, lower time spent outside, lower time in-person time with friends, and lower virtual time with friends. And the parents reported 25% versus less than almost 16% parents perceived that there was worsening of mental or emotional health in their children. And how about the parents? Parents significantly were reporting loss of work among families with kids in virtual instruction, greater job stability concerns, greater challenges with childcare, greater conflict between working and providing childcare, higher rates of emotional distress, and difficulty sleeping. So what about change in acute mental health service use, early evidence? And what was really important here was that when the pandemic hit, um, we really didn't have time to do a lot of primary data collection. What you saw, as I showed you in the literature, was some natural experiments that people were able to turn around quickly and report. But here we can look at service use using existing data. And one really impressive uh, database comes through our CDC. And what they're able to do even faster than any journals is quickly analyze their public data and turn it around quickly within the morbidity and mortality weekly report from the CDC. And this was a landmark report that came out led by Dr. Rebecca Lieb. And Dr. Lieb was actually one of our speakers at our Academy's research symposium. And what she found is she used data from the CDC National Syndromic Surveillance Program. She looked at mental health ED visits, restricted it to children less than 18. And she looked at the time period between January 1st and October 17th, 2020. And what she did is she compared it to the same calendar weeks the year prior, 2019. And what she found, and this we also experienced here at UCLA, was right after the school closures, when we were at shelter at home orders, there was a drop of 43% decline in the number of mental health ED visits. Between April, the proportion of visits, however, was much higher among those for mental health versus physical health. And here we see a rise of 66% in mental health compared to physical health. And between mid-March and October, there was a drop, again, on average of weekly ED visits. But when you stratified by those for physical health versus mental health, you see on average a 44% increase. And here was what it looked like when you graphically depict it. And you see that the solid line is the 2019, the dashed line is the 2020. And you see here on the first table, mental health related ED visits. And so you can see here on 2020, the abrupt drop and then the rise. And what's important here is the second table, the bottom table, B, looking at the proportion of mental health related ED visits standardized per 100,000 pediatric ED visits per week. And here you see much clearer, you see the dotted line, the mental health. The mental health visits are much higher proportionally compared to last year. And then also they were able with this database to stratify by age. And so the top table there, top figure is the children age 0 to 4, not as much difference. The middle figure is children age 5 to 11. You see slightly higher proportions of mental health. But here, when you see adolescents, you see again much higher proportion of mental health visits among our teens aged 12 to 17 compared to the prior year. And so in addition, there was also some quick turnaround. A team here, Paulina Krass, who's a pediatrician at Children's Hospital in Philadelphia. What they did quickly was they looked at their EHR data. They looked at emergency department mental health visits. They looked at children age 5 to 24. And in the pediatric literature, they often go up to age 24 with the, where they, in pediatrics, they feel that 25 is a cut point now for children. And they looked at the time period, April through December 2020. And they didn't exactly match the calendar months like the other group. What they did is they just looked back between, it sounds like more their existing data from January 1st, 2018 to March 2020. And here they also found within their hospital a reduction in the number of mental health ED visits. But again, the proportion of mental health ED visits was slightly higher. Prior to the shelter in place, 4%, after 5.7%. And here they looked and they stratified by age, sex, ethnicity. And what they found was higher rates among the female, white, older children, and commercially insured. Now, in this data set, they said they could not find significant differences between Hispanic versus not. But one of the big issues here is this was EHR data, and they had a lot of missing data for that variable. So that's difficult to really interpret there. And here is, again, their findings graphically, and the most important one is really the middle graph, where you see the proportion of ED visits for mental health conditions. It drops and then it spikes in 2020. And this also was an important study. It came out led by Ryan Hill, again, a pediatrician. And what they did is they actually looked through their EHR data and they looked at completed suicide screening as their data source, looked at children 11 to 21, and they compared here January, July 2019 to January, July 2020. And here they found, using the suicide screenings, higher rates of suicidal ideation, particularly in the months of March and July 2020. And using again findings from the screener, higher rates of suicide attempts in the following months, February, March, April, and July. And here it is graphically. And one thing that was important here was a research letter came out led by Peter Gill. And what he did is he used discharge data from 42 US children's hospitals. And he restricted it to 0 to 18, looked at the year of 2020. And what he did is he compared the time period of March through May compared to June through August. And here he too documented a decrease in all-cause hospitalizations during the early phase, particularly for respiratory failure, cellulitis, and epilepsy. But when he stratified by season, what was interesting and what was important for mental health was he found that there was no significant decrease in suicide or self-injury hospitalizations. And in the spring, it was about a decline of 14.4%. And I think we experienced that too, that maybe our census went down. People were avoiding the ED. However, in the summer, the rates of hospitalizations for suicide and intentional injury actually were increased by 11.8%. And again, now, thinking about our experience on call, this data really validates that. And what's important here is in the pediatrics literature, you see here that even though most of the conditions they looked at were for physical health, they did a good job pulling out suicide, intentional self-injury, and major depressive disorders. And you can see the first column is the spring, right after the school closure, and then the summer. And what's most important here is you see no significant difference in the number of admissions for suicide and intentional self-injury during the spring, right after the COVID hit, and during the summer. And you see some difference in depression, a little bit higher. Excuse me. Um, no, what's most important here is the depression in the summer rates were the same before and after. Apologize. Okay, so what about the change in acute mental health services in U.S. children's hospitals? And the research letter that came out that I just presented really kind of inspired us to look further into the question about acute mental health services among U.S. children's hospitals. And so we had several research questions for our study, again, guided from that earlier literature. One was, does the percent change in ED discharges and hospitalizations between the spring and the fall of 2020 differ between physical health and mental health? Remember, most of the data that we had when we were creating this analysis was really during the very acute phase. And now what was happening was hospital discharge data was starting to be released into the fall and available for analysis. The other question we had was, does the extent of percent change in acute mental health care encounters vary by child sociodemographic characteristics or medical complexity? And this was important because, as you can see, when in the beginning, we talked about concerns about accentuation of healthcare disparities during the pandemic. But you can see early on in the literature that for whatever reason, the data sources did not have that bandwidth to really look at this question. What was really important to me as a psychiatrist that I think was missing in the earlier pediatric literature was that they did not look at the type of mental health disorder. They were just lumping them all. And so I thought it was important to ask the question, did the prevalence of the primary mental health disorders among acute care encounters substantially change following COVID-19 closures? And then again, I think something that needed to be drilled down a little bit more clinically, because pediatrics would never like lump asthma and cellulitis together, and as psychiatrists, we shouldn't lump our developmental delays with our major depression and our PTSD. So the good thing about this data source is it was large enough that we could actually look at acute changes by type of mental health disorder. So here were our methods. It was a retrospective cross-sectional cohort study. Our main outcomes were the percent change in ED discharges and hospitalizations, and we stratified it by all causes, primary physical health, and primary mental health. Then we also wanted to say pre-post national school closures. And so what we did was we examined the 36 calendar weeks, the spring fall time period in 2020, and compared it to the matching calendar weeks in 2019. And if you remember in the earlier literature, what some of the signals were, where they also saw seasonal variation, that there was a difference, something was happening between spring, summer, and fall of 2020. And I think that was really key. Also thinking in terms of schools shutting down, then going through the summer, and then variable re-entry into virtual, hybrid, or in-person school, depending on region of the country. So we also stratified by season. And here's the data source, our Pediatric Health Information System, which is hospital discharge of US, among 44 US children's hospitals. And the age range we chose were children aged 3 to 17. So some of the study variables were, of course, the demographic characteristics, medical complexity. That's an important one to always adjust for. We used the Fuder's complex chronic conditions classification system. And here, like I was saying before, like, well, we don't want to lump all mental health disorders. We want to understand, at least from a child psychiatry perspective, what types of disorders might be driving use. And so here, what we used was the Child and Adolescent Mental Health Disorder Classification System that I led the development of. And it's able to classify using ICD-9 and ICD-10 diagnoses into 23 groups that map onto the DSM, and also includes a group for suicide self-injury. And also, it was really important that there was very little in the literature that asked the question about children who were likely receiving special education resources. And was there any way in this data set for us to develop a variable for that and to test the hypothesis that particularly our children that were receiving special ed resources and then abruptly were not, what was happening with their acute mental health care use. And so what was important here was we looked through the Individual with Disability Education Act, and we abstracted every single diagnostic category that fit eligibility criteria for this federal legislation, and created a variable there for children more likely to receive special ed services. And so, for example, that included things like autism, developmental delays, communication disorders, ADHD. It was also important that we look at anxiety-related disorders. There was a little bit in the literature, again, more sort of commentary, speculations, papers just sort of raising attention about child mental health during the early pandemic. And there was at least one author that was concerned that children with anxiety disorders while remote learning might actually be doing better at home, but would have more difficulty with reentry in school. And so we also created a category for anxiety-related disorders to see whether there was differential decline or rise in mental health ED visits and hospitalizations. So here is our final sample, almost 2 million children across both time intervals with any acute care encounter. And here you see in our 2019 sample, it was about 1 million and 200,000. Because we took all comers, we explored to see how much overlap there would be. And fortunately, almost more than 78% had only one encounter. We did the same in 2020. We had slightly more than 750,000 children in the 2020 year. And here you see 83% had only one encounter. So what was our first question? Does the percent change in ED discharges and hospitalizations between the spring and fall of 2020 differ between physical health and mental health disorders? And here we did see and documented that there was a significant difference between physical health and mental health. We also were able to document that between the spring and fall of 2020 compared to 2019, matched by calendar weeks, that all-cause acute encounters dropped by 44%. ED discharges dropped by 48%. Hospitalizations dropped by more than 25%. But when we looked at mental health versus physical health, what we found was that the percentage decrease in acute mental health care was far less than the percent decline in acute physical health care. What's important here is when we looked at any acute mental health care, that means lumping ED and hospitalization, the drop was 2.4 times less compared to physical health. When we looked at just mental health ED discharges, it was about 2 times less compared to the drop in ED discharges for physical health. And when we looked at mental health hospitalizations, the percent decline was 3.4 times less only a drop of 8% between the pre and the post compared to physical health. So again, if you guys thought you were busy when the COVID pandemic hit, you're absolutely right as far as when you were on call. And then how about season? Here we see that acute care encounters substantially declined for both in the spring. And so that's very consistent with the literature. And again, with 44 children's hospitals, it really sort of adds and further validates studies from other data sources. When we looked at the summer and fall of 2020 for primary physical health, the decline in ED discharges and hospitalizations persisted. And you see in the summer and the fall, they continue to be low for physical health. But how about mental health? Here, there was some decline in ED discharges, and then an actual rise in hospitalizations. And what you saw in the summer after the closures of school, ED visits for primary mental health had minimal decline, less than 3%. And our hospitalizations during the summer after the closure was up almost 5%. And in the fall, a drop, again, about 13%. But here you see hospitalizations that there's continues to be higher rates compared to pre-COVID of an increase of 4.4%. And those are hospitalizations for mental health. And here is again sort of by week. You can see graphically the change. The dotted is the primary mental health hospitalizations. The solid blue is the primary mental health ED discharges. And then the black is our physical health. So you can see again, consistent, proportionally higher rates of hospitalizations and ED discharges for primary mental health. Okay, what about the next question? Does the extent of percent change in mental health acute care encounters vary by sociodemographic characteristics or medical complexity? Well, what do you think? Here, we did find that the percent change in primary physical health and primary mental health care encounters did differ by age, race, and ethnicity and payer. And here we found that within the spring-fall time period, the decline in mental health ED discharges was different among the age groups. And you see here, among our teens, only an 18% decline compared to substantially greater declines in our younger kids. And here, when we stratify by sex, you see female decline is far less compared to males. And there was little change in mental health hospitalizations during this time period. And when we looked again at by sociodemographics, we see teens only a decline of like 3.5% compared to pre-COVID. Minimally no change for girls. Whites slightly down 6%, commercially insured slightly down 4% compared to pre-COVID. And then we asked the question, okay, what were the 5 most prevalent primary mental health disorders before and after COVID closures? And here you see in this table, it's spring, fall. We lumped acute care together, and then we looked at ED only. We looked at hospitalizations. And across pre and post is depression and suicide. And you see here pre, more than 50%, post, slightly more than 50%. Same thing with ED. Suicide and depression remain the most prevalent, and the same story holds true among hospitalizations. The next question was, did the prevalence of primary mental health disorders among acute encounters substantially change following COVID-19 school closures? And here, and this was the analysis that I felt was the contribution of new knowledge. And here what's important is the darker bar is our ED discharges, our lighter blue bar is hospitalization. And what you see here is the rise in hospitalizations for suicide and self-injury at 12.8%. We also see, interesting, even though the sample size is relatively small, for feeding and eating disorders, ED discharges and hospitalizations both rose after the school closures. Um, and I think, clinically, we all experienced that our eating disorder unit remained very busy when we were on call. You also saw, interestingly, a rise in hospitalizations for psychotic disorders at 10.8%, whereas the others, the declines were less substantial. But what was most important here was our hypothesis about the vulnerability of children likely eligible for special education resources. Well, our hypothesis wasn't held out by this analysis. And what we found was ED discharges remained very, very low and declined by 42%. That's similar to sort of the rates of all cause hospitalization and ED use, excuse me, and hospitalizations declined only 22% among our kids likely eligible for special ed. In here, we also remember we had a question about anxiety disorders, following up with uh, one sort of commentary that was in the pediatric literature. And we did, however, document continued decline in ED and hospitalizations compared to pre-COVID. But again, not as much as like for all causes. Okay, how did the percent change in mental health ED discharges between seasons differ? Was there a seasonal effect when school closed and then summer and then fall? And here you see among emergency department discharges um, that again, we see that among suicide and self-injury in the summer, ED discharges was highest at 22.6%, and then slightly declined, but still was higher than 2019 at 5.7%. And here we looked at hospitalizations. And again, we see on that blue line, suicide and self-injury, a disproportionate rise of 20% in the summer, which climbed to an increase of 41.7% in the fall compared to pre-COVID. So one of the other questions we had was what was the percent change in acute mental health encounters between seasons for suicide or self-injury by child characteristics. So we drilled down one more time on sort of what is driving that rise in suicide and self-injury. And here we stratified by age group and we stratified by sex. And what we see here is among our teens, hospitalizations for teens 12 to 17 related to suicide or self-injury rose 43.8% in the fall of 2020 compared to the fall of 2019. And here again, girls. Females had almost a 50% rise in hospitalizations for suicide or self-injury in the fall of 2020 compared to the fall of 2019. So with any study, we have limitations. And I think the major limitation, which is really a trade-off. I mean, it's good to have hospital discharge data. We can turn it around as soon as it's completely entered. But the problem is that in this hospital discharge data, all emergency department visits are underestimated. So the way this data source was created was that we only have discharge data. So these are ED encounters that included only discharges. So therefore, our mental health hospitalizations are also potentially underestimated because it did not include transfers to freestanding psychiatric hospitals. The other thing too, it's important is that these were tertiary, for predominantly tertiary freestanding children's hospitals. So they're not generalizable to other healthcare systems serving children. And the other thing too, again, this was discharge data. So things like child, parent, community level variables were not available, which really, this data set was really sending a very kind of a large national signal among US children's hospitals, but we were not able to examine, for example, clinical need or the impact of hospital avoidance or some of the worsening of social determinants of health related to COVID-19 that I mentioned early on in the talk. So in conclusion, um, following COVID-19 school closures, unfortunately, suicide or self-injury and depressive disorders continued to drive acute mental health encounters in 44 US children's hospitals during the additional strain on children and their families, as well as mental health systems. And in particular, adolescent females were vulnerable, as evidenced by their substantial rise in emergency department discharges and hospitalizations for suicide or self-injury in the summer and fall of 2020. So what are the implications? One of the things that we tried to drive home on this paper is that public health strategies to improve child safety during COVID-19 pandemic should place high priority on suicide risk reduction, especially for adolescent females. So here's how to reach me. And here's all my references. And we'll open it up for any questions.
Hi, folks. To kick off our discussion here, one question coming in. Dr. Zima, can you talk more about selecting a group of children more likely to receive special education resources and what might explain their drop in hospitalizations and emergency department visits?
Right, right. Well, we really don't know the explanations from this data source, but what was really most important here was we were the first to call out and create a study variable for likely eligible. So that included ADHD, communication disorders, developmental disorders, learning disorders, and I'd have to double check a few others. But we don't really know. And I think what's going to be important now that children are returning to school is we really need a better data infrastructure that will link both education and mental health together so we can see how these children are going to be doing post-COVID, right? I'm not sure that answers your question directly, but
We have another question coming in here. Do you have any information on these rates for other genders and gender expansive youth?
Well, we were only able to stratify by female and male, given the data set. It was discharge data. But hopefully in the future, particularly when we use EHR data and if folks can really document well in their EHR, gender minority, then we'll have more capacity to look at that difference. And that's a good question because, you know, LGBTQ kids are at higher risk for suicide and self-injury. And I think that would be a really important study to look at, see how they're faring over time.
Another question coming in here. Great talk, worrisome data. Any way to translate these data to population rates to inform workforce needs?
Oh, that's pretty cool. Um, I like that question. I think with this data source, we can't, again, because it's hospital discharge, but, um, but you know, what's really important in that question is that we need more primary data collection on need, which is really, really hard to do. And unfortunately, I don't think unless people were piggybacking onto existing longitudinal studies, their COVID-19 questions, we weren't able to really capture in real time increasing need. But hopefully in this next year, some of the data sets that might have gotten additional COVID supplements to add onto their primary data collection can actually document that better. So with this study, with the discharge data, it's at best a signal. And one of the limitations was we didn't have need. But that's a really good question.
Another question here is, do you have thoughts on measuring types of instructional disruptions and the role of school-based, like transition to hybrid, virtual?
Yeah. Actually, we have a NIMH 1 under review, and we actually proposed using school district level data and merging that with EHR data to look to see about differences in the time during shutdown, virtual instruction, hybrid, in person. But that data sources would be coming from school district level data that varied. And I need to be mindful too, because I think just for Zoom fatigue, maybe we'll take one more question. I think it's important that the fellows in particular have a 10-minute break.
Another question came in. Do you think that discharges diagnosed as suicidal ideation may underreport comorbidity like depression?
Yes, absolutely. And so the other thing too is when you look at those two prevalence rates, they're both high, depression and suicide. It's dependent on the documentation, right? So that's why I like to look at them both because we don't know, and they are related. And again, the Achilles heel with discharge data is all we can do is work with what's documented in that discharge, right? So it could be underreported. And this question also brings up the issue of, well, what do you do about kids that have severe traumatic injuries that maybe don't get labeled suicidal at that primary hospitalization because they're being shipped up to surgery, or they're in the ICU. So they're getting missed as well. So we probably are underestimating.
Well, I think our plan was to wrap up a little bit early this morning.
Yeah. Yeah, and I will stay on if people want to talk, but I do want to be mindful of Zoom fatigue and give a shout out to all of our trainees who have done an incredible job training under COVID and under Zoom. We really appreciate their perseverance with us also learning how to teach virtually. And I'm available by email if anybody wants additional time. Okay. So I think we can say goodbye. All right. Thanks, everybody. Take care.